Hello everyone, I'm Dr. Afrin Rajoy and today we are going to talk about integrated care models. The next three slides has some numbers and statistics just for your information, so please take your time and look at the numbers and the figures. So let's talk about collaborative care model. In terms of clinical approach, collaborative care programs follow the principles of measurement, base care, treatment to target, and stepped care, and other aspects of the chronic care illness care model proposed by Wagner and his colleagues. In collaborative care, each patient's progress is closely tracked using validated clinical rating scales such as PHQ for depression, GAD for anxiety, and so on. And treatment is systemically adjusted. So if patients are not improving as expected, we can go to the next step. And initial adjustments can be made by the primary care treatment team with input from the psychiatric consultant. And about collaborative care model evidence, randomized controlled trials, which we call RCTs, show that disease management models using care managers are both clinically effective and cost effective. So there are many different studies, meta-analysis indicate that there is a cost offset of 20 to 40% of primary care patients who receive behavioral health services. And fewer hospitalization results in significant cost reduction for patients with chronic physical illness and those with psychiatric diagnosis. And this, research that I'm talking about, this study is from, it's old, like from 2007, but it's still valid. The largest trial of collaborative care to date, the IMPACT study, IMPACT with capital letters, included 1,800 adults aged between 60 and older with depression in 18 primary care clinics in 5 states. And they did this evidence-based depression care, and it was like it showed that it was effective. The other thing that I wanted to mention is more than 70 randomized controlled trials have shown that collaborative care for common mental disorders such as depression, they can be like more effective and cost effective than usual care across diverse practice settings and patients populations. So it's not just that in theory or on paper we think that collaborative care is effective, but also evidence and studies, they show that as well. There's this quote that I really like. It says, if primary care treats the body and mental health treats the head, integrated care is rediscovering the neck, which says a lot, right? So integrated care rendered by practice team of primary care and behavioral health providers working together with patients and families and using a systemic and cost-effective approach to provide patient-centered care. So collaborative care is about working with primary care team, but integrated care is about working within primary care team. About integrated care models, as we talked about it so far briefly. Bill Doherty talks about it, and some people after Bill Doherty. And basically, we have 5 levels and 6 levels, kind of like 2 models, but they're very similar. And I'm going to talk about the 6th level one in the next slide with an example, so we can have a better grasp of what we are talking about. But basically, they are about the differences are about the location, how we use the shared system or a non-shared system, communication, collaboration, and the culture of of being in a team-based program or not. This table, as you see, it's from SAMHSA, and you can visit SAMHSA, and actually you need to familiar yourself with SAMHSA and the different blogs and content that they have. But this is about the 6th level of integrated care, and I'm going to talk about the different levels with an example. But before we go through detail, I just wanted to say that when we talk about different levels, some people, they think that at the end of the day, our goal is to have level 6, like fully integrated system all the time, always. And that is not the case. As Bill Doherty says, each of these levels, they can have, pros and cons and their own function. And the important thing is that we become mindful of where we use what and why we use them, right? So just keep that in mind while we are talking about all these different levels. So as you see, there are 3 different categories: coordinated, co-located, and integrated. When we are talking about coordinated care, the key element is communication. And we are talking about level 1 and 2, which is about minimal collaboration and basic collaboration at a distance. So imagine we have a patient called Jack, and Jack has diabetes and depression at the same time. And he needs to see his primary care and a behavioral health professional therapist, and he also needs to refill his medication, right? So when we are talking about, excuse me, coordinated care, integrated care, when we are talking about coordinated care and, level 1 and 2, Jack needs to go to different facilities. So one facility to see his primary care, one facility to see his therapist, and another location to at a pharmacy to refill his medication, right? So basically, at level 1 and 2, different professionals, healthcare professionals, they have separate systems, they have limited communication, and they have limited understanding of each other and each person's role, right? So to make it very simple, at level 1, if the providers, if they meet each other somewhere, like level 1, they will be like, who are you, right? So they even don't know each other, so may never meet in person, right? And at level 2, their reaction would be like, okay, you helped my patient, but you didn't help me, right? So they may meet as a part of a larger community. They may have communication or collaboration about, patients who are maybe difficult or have specific issues, but it's not a routine. It's not a part of the culture that they are living in. So the next category is about co-located care. And the key element here is physical proximity, right? So level 3 and 4, it's about basic collaboration on site and close collaboration on site with some system integration. So at level 3 and 4, there's the same facility, but not necessarily same offices, right? Level 4 may have some same space, but it's still like the offices are different. So let's say in this case, Jack, if he wants to, follow up on his health concerns, he goes to the same facility, but the offices are like on different floors, and they're not the same. So at level 3, they still have separate systems. At level 4, they have some shared system. For example, there's this front desk in the building about scheduling or medical records, something like that. But they do not have access to each other's, the healthcare professionals, they do not have access to each other's notes or recommendation or stuff like that. So at level 3, collaboration, it's driven by need for each other's services, and it's more reliable on referral, right? And level 4, it's driven by need for consultation and coordinated plans for difficult patients. So again, like, it's not part of a routine process or part of a culture. So level 3, they meet occasionally to discuss cases due to close because they are in the same facility. Level 4 have regular face-to-face interactions about some patients. And at level 3, they feel part of a larger, but they still do not have that, feeling of like, yes, we are the same team, right? But at level 4, they have this basic understanding of the roles and the culture, right? So basically, level 3 and 4 would be like, if the healthcare providers, if they see each other, they would be like, yeah, you help me and my patient. Then we go to integrated care, which is the next category, and the key element there is practice this change that we want to bring into the system, right? And level 5 is about close collaboration approaching as integrated practice. Level 6, full collaboration in a transform merge integrated practice. So at level 5 and 6, obviously the facility is the same. At level 5, there are some same space, but level 6 is like fully the same facility sharing all the practice space, right? So in this example, if Jack goes to the same facility, probably a little bit different between level 5 and 6, but at level 6, for example, Jack stays in the same room, and medical assistant, primary doctor, mental health profession, a person for refilling the medication, all these people, they come to the room and they go, right? So but Jack is in the same room. So they actively seek solutions together, the team, and they have shared systems, and they have collaboration and communication. At level 5, collaboration is driven by the desire to be a member of the care team. Level 6, driven by shared concept of team care. And they have this fully understanding and culture of being the same team. So again, like if the healthcare professionals, if they see each other at level 5 and 6, level 5 is like they have this fully understanding that they are excited that we are the same team, and we are here to help the patient and the family. And level 6, their interaction would be, we are not only happy that we are the same, we are in the same team and we are helping the patient and the family, but we are also here to inspire other people to be part of a team. So as you just listened to and saw, the models of integration could be different because of and based on levels of collaboration and integration, evidence-based and promising practices, population served, right? The community that we have the practice, culture, language, different factors, cost of the model, local resources for referrals, training of providers and staff, we should have resources for that, and investment across the 4 worlds of CJPs, right? Operational, clinical, financial, and teaching. So based on all these different things, the model that we are using in a healthcare system could be different. And again, like the point is not to have level 6 in all the places at any time, right? But the point is to be mindful of what do we have and why do we have that, and what is the best option for that place, for that location, for that population, for that time, right? And again, like this comes from my personal experience, but it's also important to pay attention that if you're working at a healthcare setting, sometimes they say that their model is like level 4 or 5 or whatever, but when you are there, you actually feel like this is not level 5, this is level 3, right? Or this is like the culture there is like level 4. So again, like it's important what we do, how we do that, and why do we do that, and what do we claim about that. So now that you are familiar with the different levels and their characteristics, and you know that each of them, they have pros and cons, and they could be valuable, at a specific location at a specific time, right? There are some good questions that you can ask if you are working or, doing a research at any of these levels, right? For example, at level 1, minimal collaboration, some good questions include, is information being shared at all? Are releases being obtained for communication? At basic collaboration at site, at a distance, level 2, some good questions include, is information being shared in a timely manner? Are releases being obtained for communication? Is information, do we, go with confidentiality for, communication and, information that we are sharing? Are providers communicating in a professional, respectful manner, right? And then we go to the next level, which is about basic collaboration on site. Then some good questions include, are consults being handled in a timely fashion? Is there communication after referral, right? Or do I just refer the client, the patient, and I don't care about, the next steps? If so, is communication conducted in a confidential and respectful way, right? Or do we start talking about patients when we are at lunch, and there are all these different people coming and going? So another question is, how do providers respond to inquiries from those not involved in a direct care? Do treatment plans influence each other, right? Then we are talking about close collaboration in partially or partly integrated system, right? Like level 5. Some good questions include, does the team maintain appropriate professional boundaries? Do the members of the team stay within their own skill sets? Or just because I've been there for 2 years now, I can talk about the medical part of high blood pressure, low blood pressure with patients, because that is not appropriate for mental health professional who does not have expertise in the medical world, right? So another question is that, is there appropriate follow-up by each team member? How does the team handle disagreements, right? In medical family therapy, we talk about collaboration, right? To refresh your memory. And then at last level, which is close collaboration in fully integrated system, like level 6, some good questions include, does care of the system avoid inappropriate therapist provider staff relationships? After team members share knowledge, do they operate within their own clinical capacities and skills and competencies? Are team members acting cohesively, right? Are team members operating in the best interest of patients, incorporating all team members' perspectives? So those are some good questions that, again, like, we can ask ourselves, we can use if we are directors, we are leaders in the healthcare systems, and or if we are supervisors or doing studies in these different settings. Again, this is a summary of what we've been talking about. Now let's talk about some other concepts and approaches in integrated care models. One concept that we have is triple aim, and triple aim is an approach to optimizing health system performance, proposing that healthcare institutions simultaneously pursue three different dimensions of performance. The first one is improving the health of population, second, enhancing the patient experience of care, and third, reducing the per capita cost of healthcare, which is super important, especially like in United States, because as you know, we are the richest country in the world, but the healthcare system rate that we have in the world is the last time that I checked it was around 34, which is not interesting. So the primary triple aim goal is to improve the health of the population with two secondary goals: improving patients' experience and reducing costs, contributing to the achievement of the primary goal. Keep in mind that both of the things that we mentioned, improving patient experience and reducing cost, both of them, they're important, because in the US we have amazing sometimes patient experiences, but when you look at the cost, those are not for everyone, of course. So, and as we're talking about health and healthcare, and those are just health and healthcare, they are human rights. We need to be mindful of improving the quality and at the same time reducing the cost, so it would be more accessible and reachable for everyone. Then we have a quadruple aim. So while the triple aim, enhancing patient experience and improving population health and reducing costs, is kind of like widely accepted as a compass to optimize health system performance, so physicians and other members of the healthcare workforce report that burnout and dissatisfaction with like this concept and this approach. Burnout is associated with lower patient satisfaction and reduced health outcomes, and it may increase costs. So you can see how it's like a kind of like vicious cycle, right? And burnout, you can actually kind of like is linked with triple aim, which is not good. So because of that, adding the fourth aim of the three that we were just talking about, and the fourth one, which is improving the work life of healthcare providers, including clinicians and staff, that also became an important aspect of the goals that we have and what we want to do, the approach that we want to take in healthcare systems. Please take some time and review the kind of like model that you see here. Okay, so one question here can be, okay, I've heard you, like the fourth aim that you were talking about, it sounds great, but what are some of the practical tips to move towards that? How can we be mindful of healthcare professionals, health and, the burnout and fatigue and stuff like that? So there are different things that we can do. The first one is implementing team documentation. So nurses, medical assistants, or other staff, they can present during the patient visit. They can, enter some or all documentation into the EHR and assisting with order entry, prescription processing, and charge capture, right? So basically we are thinking about distributing the responsibility to some extent, if we can, and not, make one person of the healthcare system or one or two roles very exhausted. We know that team documentation has been associated with greater physician and staff satisfaction, improved revenues, and the capacity of the team to manage a larger panel of patients while going home earlier. So that's great news, right? The other thing is use pre-visit planning and pre-appointment laboratory testing to reduce time wasted on the review and follow-up of laboratory results. The other tip is to expand roles, allowing nurses and medical assistants to assume responsibility for preventive care and chronic care, health coaching under physician written standing orders. Then we can have standards and synchronize workflows for prescription refills, an approach which can save physicians 5 hours per week while providing better care. Then the other suggestion is to have co-locate teams. So the physicians work in the same space as their team members. And this has been shown to increase efficiency and save 30 minutes of physicians' time per day. And if you see any physicians around yourself, or even like if you've just been to different healthcare facilities, you know that 30 minutes per day for a physician, saving that time, it's a lot. So the other thing is that to avoid shifting burnout from physicians to practice staff, we can ensure that staff who assume new responsibilities are well trained and understand that they are contributing to the health of their patients, and that unnecessary work is kind of like ranging out of the practice. Again, when we are talking about all these different tips, what do you remember? What does it remind you of, right? It reminds of us the four world of CJ Peaks. It reminds of the different levels of integrated healthcare system and integrated behavioral healthcare settings, right? And it reminds of all the different things that generally we talk about when we talk about medical family therapy, right? So one of the most popular models of care to come forward in recent years is this idea that you see on this slide, this idea of the patient-centered medical home. And as you can see, this model kind of like envision the primary care office as the patient's home in the broader medical system. And patient-centered medical home has 5 main principles. It's physician-led. It's about whole person orientation, or it has this whole person orientation kind of like perspective. It's about integrated and coordinated care, focused on quality and safety, and it's about kind of like having access for patients. It's a priority for the system for patient-centered medical home. So when we talk about PCMH, how does the team-based care work there? So it's relationship based, two or more professionals working together to improve patient care. And the team-based care there is very flexible, so it's built around patient population needs. And it's very, as it sounds, it's very patient-centered, which means, greater opportunities for expanded office access, greater focus on education and self-management. And it's very, physician dependent. So value of model stems from clinical efficiency and expertise. Complex patients get physicians increased focus in this model. Then we have some lexicon for integrated care, and I explained each of them in one of the previous lectures. So if you want to get familiar with the definition or what we mean when we use, for example, primary care or patient-centered medical home, I can go back and watch that lecture again.
So now let's talk about the PCBH model, the primary care behavioral health model, which is a population-based service in which the BHP, behavioral health professional, is available to PCP, primary care professional, and patients on the clinic floor. And they're also available for phone and electronic communication. And so the kind of like scheduling is minimal. Behavioral health professionals function as generalists who are visibly part of the medical team during patient appointments for consults to primary care professional and or for frequent warm handoffs. So behavioral health professionals assist in diagnosis and provide psychoeducation and brief interventions such as teaching relaxation or grounding skills for various behavioral health conditions such as, sleep issues or anxiety. Services match the pace of primary care and are focused on maximizing patients' functionality and self-management. So with behavioral health profession, they encounters kind of like averaging less than 30 minutes and providing 1 to 4 consultants per patient complaint, and seeing 10 to 15 persons of patients for longer duration. So basically you see patients for 20 to 30 minutes, and then if they need what we call traditional sessions, if they need you see them for longer session, then you can schedule them for traditional sessions. But it's not like that, like traditional setting, right? So usually 10 to 15% of patients, they will be scheduled for the longer sessions. The other thing about this PCBH model is that PCBH model has been shown very effective when targeting about 16% of the clinic's patients seen per day and addressing routine as well as complex patient presentations. So in addition, utilization of PCP visits has been shown to be lower during the behavioral health professionals service period, and for up to 12 months there with significant improvement over usual care, which are all great news, right? Again, it's not something that we just talk about; it's evidence-based. The PCBH model, it's about a behavioral health consultant, BHC, right? We call it BHC, behavioral health consultant, offers brief intervention services to children, youth, adults, often on the same day of the client's visit with the referring PCP or nurse. The behavioral health consultant uses evidence-based interventions adapted to the brief context of primary care and translates these to even briefer versions of the BHCs can teach to the briefer versions that behavioral health consultants can teach, and they can teach to the primary care professions and nurse members of the team. The behavioral health consultant is considered to be a primary care provider rather than a specialist, and charts in a medical record rather than a separate mental health record. So the BHC does not have a caseload, does not open or close cases, and is easily accessed by clients and family members on an intermittent basis over the course of their lifetime. Again, like that information that we just talked about PCBH, I think it's very important to keep in mind as we are getting familiar with all these different models, and we reviewed them today.
If you decide to be a behavioral health consultant, you should work on your clinical practice skills, practice management skills, consultation skills, documentation skills, as usual, team performance skill, and administrative skills.
And one of the last models that we are going to talk about today is chronic care model. And the disease management model was developed by Edward Wegner and his colleagues in 2001. The disease management or chronic care model is an integrated system of interventions to optimize functioning of patients and to impact the overall cost of the disease burden. This practice model emphasized both the early identification in primary care of populations that are at risk for costly chronic disease, for example, depression, diabetes, asthma, and the provision of educational orientation and evidence-based algorithms. So disease management models have an organized approach to assisting lifestyle modification. And a care manager provides follow-up care in this model by monitoring the patient's response and treatment. The care manager also provides education to the patient about his or her disorder and self-management strategies. Care managers may be nurses or master levels social workers, and these professionals may provide brief psychotherapy if needed. So provide the services that we just talked about could be also obviously, by a medical family therapist as well. The disease management model shares many similarities with the co-location model. So the distinction is that behavioral health interventions used in pure co-location models are typically specialty mental health interventions that are brought into primary care. The disease management model also involves co-location, but the clinical interventions are typically modified for the primary care setting. Another thing that we should talk about is that disease management model is the use of a patient registry, for example, one that identifies all patients with chronic pain and depression. Special programming is targeted for this population, and patients are routinely monitored by a care manager to ensure that defined interventions are completed.
There are 6 main core competencies for medical family therapists, and we have talked about them before, but I have them on this slide just to refresh your memory. So again, please take your time and read them and read the definition. What should you expect if you decide to work as a behavioral health consultant at a healthcare setting? So there are different things. So first of all, there are a variety of methods for getting patient to the office, right? Or a behavioral health consultant. Sometimes the primary care professional, they go first. Sometimes the behavioral health consultant, they go after the primary care professional, and sometimes they go in the room together. And there are a variety of problems and ages. So they can be clinical problem, such as depression or different things that you're familiar with, and they could be case management or care coordination. In that case, you can work with the social worker who works at the setting, or depends on the setting and the team members that you have. You can ask for help, or you can work together. Then we have variety in the goals of the visits. So sometimes it's about treatment augmentations. Sometimes it's about medication and treatment planning, and sometimes it's about primary care professional and the preparation that you need to do for that visit. The next 3 slides, they include some sample clinic complexity and diversity. So again, please take your time and read them.